CCRN Electrolyte Imbalances Practice Test Questions Study Guide, 25 Most Asked Questions. Question 1. What is a common EKG finding in a patient with hypokalemia? Peaked T waves, prominent U waves, widened QRS, shortened QT interval. Hypokalemia often causes flattened T waves and the appearance of U waves. Question 2. Peaked T waves on an EKG are most characteristic of hypokalemia, hyperkalemia, hyponatremia, hypocalcemia. Hyperkalemia causes tented or peaked T waves initially. Question 3. Quast-X sign and Trousseau's sign are used to assess for hypernatremia, hypocalcemia, hypermagnesemia, hypokalemia. Both signs indicate increased neuromuscular excitability due to low calcium. Question 4. Which condition is characterized by high serum sodium and low urine-specific gravity? SIADH, diabetes insipidus, D. Cushing's syndrome, heart failure. D involves a lack of ADH effect, leading to massive dilute urine output and dehydration/hypernatremia. Question 5. What is the most dangerous complication of rapid correction of hyponatremia? Cerebral edema, central pontine myelinolysis, osmotic demyelination, pulmonary edema, acute kidney injury. Rapidly increasing sodium can cause permanent brain cell damage, demyelination. Question 6. A patient with SIADH will typically show which lab results? Hypernatremia and dilute urine, hyponatremia and concentrated urine, hyperkalemia and metabolic acidosis, hypocalcemia and low PTH. SIADH causes water retention, diluting the serum, hyponatremia, while the urine remains inappropriately concentrated. Question 7. Which electrolyte imbalance is frequently caused by alcoholism? Hypermagnesemia, hypomagnesemia, hypercalcemia, hyperkalemia. Alcoholics are at high risk for low magnesium due to poor intake and increased renal excretion. Question 8. Which medication is used to stabilize the cardiac membrane in severe hyperkalemia? Insulin, calcium gluconate, sodium bicarbonate, K-oxalate. Calcium gluconate does not lower potassium but prevents life-threatening arrhythmias by stabilizing the heart. Question 9. A patient with a serum sodium of 160 milliequivalent/L is most likely to experience seizures and altered mental status, tetany and spasms, peaked T waves, hyperactive bowel sounds. Severe hypernatremia causes brain cell shrinkage, leading to neurological symptoms and seizures. Question 10. Hypophosphatemia is a critical concern in which scenario? Blood transfusion, refeeding syndrome, metabolic alkalosis, liver failure. Refeeding a malnourished patient causes insulin surge, shifting phosphate into cells and causing dangerous serum drops. Question 11. A patient with hypercalcemia should be treated initially with calcium restriction only, for hydration with normal saline, potassium supplements, magnesium sulfate. Vigorous hydration with saline promotes calcium excretion via the kidneys. Question 12. Which electrolyte is inversely related to calcium? Sodium, potassium, phosphorus, magnesium. Calcium and phosphorus have a reciprocal relationship managed by PTH. Question 13. Torsades de pointes is a lethal arrhythmia often associated with hyperkalemia, hypomagnesemia, hyponatremia, hypercalcemia. Hypomagnesemia can prolong the QT interval and lead to torsades. Question 14. What is the normal range for serum potassium? 135 to 145 milliequivalent/L, a 3.5 to 5.0 milliequivalent/L, 8.5 to 10.5 mg/dl, 1.5 to 2.5 milliequivalent/L. The normal serum potassium level is 3.5 to 5.0 milliequivalent/L. Question 15. Insulin and dextrose are given in hyperkalemia to excrete potassium in urine, shift potassium into the cells, neutralize potassium in the gut, bind potassium in the blood. Insulin facilitates the movement of potassium from the extracellular space into the cells. Question 16. A widened QRS and sine wave pattern on EKG indicates severe hypokalemia, severe hyperkalemia, digoxin toxicity, hypocalcemia. Extreme hyperkalemia leads to QRS widening and eventually a sine wave appearance before cardiac arrest. Question 17. What is a common cause of hypermagnesemia? Diarrhea, renal failure, ing suction, diuretics. The kidneys are the primary route for magnesium excretion. Failure leads to accumulation. Question 18. Hypokalemia potentiates the toxicity of which drug? Warfarin, digoxin, aspirin, lisinopril. Low potassium increases the risk of digitalis toxicity. Question 19. The rule of tens for potassium replacement usually suggests not exceeding how many milliequivalent per hour in a peripheral line? 10 milliequivalent/HR, 20 milliequivalent/HR, 40 milliequivalent/HR, 5 milliequivalent/HR. To prevent vein irritation and cardiac risk, 10 milliequivalent/HR is the standard limit for peripheral IVs. Question 20. Which electrolyte is the primary intracellular cation? Sodium, potassium, chloride, calcium. Potassium is the major cation inside the cell, while sodium is major outside.